Good evening. We are Courtney Forbes, Jordan Johnson, Ashlyn Rhodes, and Katie Cowart. Today, we are discussing our quality improvement proposal on reducing readmission rates for heart failure patients. We are students with WSSU's ABSN program working with Dr. Marquita Taylor. Atrium Health Wake Forest Baptist Hospital faces an ongoing challenge of reducing 30-day hospital readmission rates for heart failure patients. These readmissions negatively affect patient outcomes, resource utilization, and nurse workloads, leading to a significant waste of resources, including time, finances, and staffing. That is why it is imperative that this med-surg floor focuses on the major factors contributing to this problem: insufficient patient education and discharge teaching, lack of medication reconciliation, and inadequate follow-up care coordination. Organizing a project addressing these issues is important to the substantial costs associated with these readmissions. A study estimated the average cost of readmission is upwards of about $10,000 per patient. This project aims to improve patient outcomes and reduce unnecessary costs by upgrading the education and follow-up care given. Our goal is to establish policies and procedures that will increase the quality and quantity of discharge teaching, follow-up care, and medication management. In doing so, we aim to reduce the amount of 30-day readmissions of heart failure patients by 20% by December 31st of 2025. Here is some supportive evidence we collected for our proposal. Approximately 6.2 million adults in the United States are living with heart failure, and the 30-day readmission rate is about 30% nationwide. Two quality improvement studies we have included used the interventions we plan to implement. One QI study resulted in a 50% reduction in readmissions, while Lindsay and Welch conducted a study that proved to reduce their heart failure readmission rates from about 25 to 10%.
Like Katie said, our project is focused on reducing the 30-day readmission rate for heart failure patients on a med-surg floor at Atrium Health Wake Forest Baptist. We selected outcome measures as our primary QI metric. Our strategies include structured and nurse-led patient education on heart failure management, ensuring follow-up appointments are scheduled before discharge and within the following week, and reinforcing discharge instructions. We plan on utilizing the teach back method to make sure the patients fully understand and remember the information provided. We will also provide detailed medication reconciliation and education before the patients discharge home. As far as management goes, we are implementing many levels of leadership. The project leader will be the nurse manager of the unit. Under this project leader will be one charge nurse that will act as the clinical implementation lead and a hired data analyst that will serve as the data and outcomes leader. The team will also include a pharmacist to provide the medication reconciliation and education, and two case managers are in charge of scheduling the follow-up appointments and coordinating care. One physician will act as an advisor of the project to offer clinical guidance and support evidence-based practice. Other charge nurses and senior nurses on the floor will help make sure the strategies are being acted on. And then the bedside nurses or frontline nurses will be doing the optimized patient education and discharge process. So this project involves a multidisciplinary approach. It truly engages nurses, physicians, case managers, and management, all to ensure a successful execution. Each member of this team has a voice and a vital role. Our project will be implemented in 5 phases. The first phase involves establishing the team, collecting baseline data, and training the staff. A schedule for bi-weekly meetings will also be put into place, where all members of the team will meet and talk about successes, concerns, issues, etc. The second phase is when our new interventions will be put into action for 8 weeks. After these 8 weeks, the third phase will occur. The analyst will evaluate the data and report it during one of the biweekly meetings. The group will decide on any alterations of the program and can retrain during this time. Phase 4 includes another 8 weeks of implementation, including what was adjusted. And the last day of data collection will be December 31st. Phase 5 is when the data analyst finalizes the report, the team reviews it and plans, and the leaders present the data to hospital administration. Like I mentioned, we'll be focusing on outcome measures as our primary evaluation metric, meaning we will assess the impact of our interventions by tracking the change in patient readmission rates. We'll do this by using this first formula to calculate the percentage of 30-day heart failure readmissions, first using baseline data, and then a couple times throughout the 6-month period. We'll also calculate the percentage of patients that received the education and got follow-up appointments, just to prove we adhered to the plan. And finally, we'll calculate the percentage decrease in the number of 30-day readmissions, hopefully reaching our goal of at least a 20% decrease.
Okay, now we will talk about the budget and total cost for the project. It's comprised of staffing, training and education, tech and IT support, and a consultation class and bonuses. The amount we will spend on staffing is $75,265 max. We're only paying one member of the team full time, and that's the data analyst who makes $37,500. The remaining members of the team have these tasks already included in existing roles but may require overtime hours, and those who work overtime are paid time and a half for a maximum of 7 hours per week. Max payments are broken down on the chart. For training and education, we have budgeted for 3 online courses, 2 for the 30 bedside nurses on the unit and 1 for the nurse manager. The courses are heart failure specialist training, teach back method training, and discharge planning, which totals $1,810. Also included is education materials like papers, videos, printing and distribution, which total $750. For IT and support and technology, we have an electronic health record system with data tracking, which is $5,000, and Wiki's CareFlow, a telehealth platform that allows for follow-up calls and meetings, that is $450. Lastly, we have a bonus for the nurses, which is $200 for every nurse at the end of a 6-month period, and readmission rate decreases by 20%, bringing the total maximum budget to $88,715 with the possibility of it being lower for overtime hours.
So the benefits of this project include a couple different things. Our quality improvement project is designed to not only enhance nursing care, but also provide significant benefits to patients. So on the patient side of things, some of the benefits include a lower risk of complications, rehospitalizations. We're going to empower them through the education that they're receiving, like some of those educational pamphlets and things that Jordan mentioned earlier. We're going to make sure that the patients have their appointment scheduled before they even leave the hospital. This is going to enhance their ability to make their follow-up appointments because they know about it. We're also going to give them more support and guidance just from the healthcare team in general. This is going to help to reduce their stress and anxiety about their disease and the condition that they have. Just overall, we're going to promote self-management of this heart failure that they have. On the nursing side of things, a benefit is going to be reducing the workload of the patients to help lower the preventable readmissions to the hospital. We're going to streamline and standardize the discharge process so that every nurse knows what they need to do. Benefits also going to include stronger nurse-patient relationships and also helps to enhance nurses' critical thinking within their job process. Next steps in April, obviously first thing we want to do is secure approval and funding from Leadership Board and this QI Council. We're also going to assign the leaders, develop all those educational materials that we've been talking to you about. We want to finalize the EHR tracking system, ensure that that is working properly. Come May, we're going to go and hire that data analyst. They're going to start on July 1st, the first day of the project. We're also going to appoint our case managers and our pharmacists that are going to work along with us. Beginning of June, we're going to train all the leaders on the new protocols and educational material that we have. Middle of June, we're going to go ahead and conduct a small scale pilot project to have it start on one unit, see how it works, work with the kinks, get feedback. And then by the end of June, we want to have all that feedback accounted for, done, and fixed, and then be ready to start on July 1st. That is the end of the presentation we have for you guys today. We want to thank you so much for your time, for allowing us to talk with you. We look forward to your feedback. If any questions that you have, the next slide here that I have is just a list of the references that we used for this presentation. And again, we thank you for your time, and we look forward to hearing from you guys in the future in regards to this project. Thank you.